Chronic heart failure or heart failure, it's a clinical syndrome usually characterized by the presence of typical symptoms, which symptoms like a shortness of breath, dyspnea, general fatigue, swelling of the legs and the general edema, and edema of the feet. And some signs: increased pressure in the jugular veins during physical examining, wheezing in the lungs, and peripheral edema. And all the signs are caused by dilation of the structure and or function of the heart, and leading to decrease in cardiac output and or increased pressure filling the heart and rest or during exercising. So the key problem in the heart, it's decreasing cardiac output due to decreasing contractility function and due to increasing final diastolic pressure in the chambers of ventricles. And before the classification and before our discussion, I'll show you the slide because it's the last and the most important classification of heart failure, which caused by many reasons. And the last important classification includes classification of heart failure by the ejection fraction, which we can assess during ultrasound method of diagnostics. And in fact, ejection fraction show us the volume of cardiac output. And first, it's heart failure with the reduced ejection fraction, formerly referred as to a systolic heart failure, more preferred for systolic heart failure with decreasing contractility of the left ventricle. And in this case, ejection fraction should be less than 40% from the normal volume. Second one, heart failure with preserved ejection fraction, formerly referred to as like a diastolic heart failure. Then ejection fraction should be more than 50%. Borderline heart failure when systolic and systolic fraction and ejection fraction in the average between the 31 and 39%. And heart failure with improved ejection fraction patient with a history of heart failure, then the heart failure continuously 40%. About etiology of heart failure, there are many causes of heart failure, like a heart disease that improve ejection fraction of blood from the ventricle. And the main mechanism which leading to heart failure, first of all, it's primary dilation of contractility due to chronic coronary disease or dilated cardiomyopathy or damaging of the myocards of various etiology and caused by damage or loss of cardiomyocytes due to myocardial infection, autoimmune reaction, infection, toxic damaging of the myocard, accumulation of some substance like a hemosiderin, like a glycogen in cardiomyocytes or in the intercellular space, like in case of amyloidosis, general amyloidosis with based amyloidosis inside the cardiomyocytes. Decreased contractility of available myocardial sites, acute transient ischemia, hibernation of left ventricle myocardium with a chronic disease in coronary blood flow or stunning after an episode of acute ischemia. Overload of ventricles by pressure or volume. So first mechanism, primary dilation of contractility, damaging by many reasons structure of the myocard, and decreased contractility of available myocardial sites. Second group of the reason, it's overload of the ventricles by pressure or volume due to arterial hypertension or valve damaging or heart defect. Third group reason, diastole disorders due to pericardial disease, myocardial hypertrophy, restrictive or hypertrophic cardiomyopathy. In this group of problems, the main mechanism, it's a problem and then it's damaging of relaxation of the myocardium due to diastole, during the diastole. Next moment, it's a causes of heart failure with a reduced ejection fraction. First of all, coronary heart disease, more often group of myocardial infection and post-infection cardiosclerosis, poorly controlled arterial hypertension, valvular heart defects, and cardiomyopathy. In response to a decrease in cardiac output by various reasons, neurohumoral mechanism started to activate it, and among which vasoconstrictor factors like usually normal regulation prevails, as well as a factor which lead into the retention of sodium and water, in the body in the circulated bloodstream. After several months or year, depends on the situation, from the appearance of the myocardial damaging factors, heart starting to remodeling occurs with progressive dilatation of the left ventricular cavity and aggravation of systolic dysfunction. Caused of heart failure with preserved contractile function of the left ventricle. Arterial hypertension, and more often with left ventricular hypertrophy and association with the left ventricular hypertrophy, coronary heart disease, diabetes mellitus, hypertrophic cardiomyopathy, restrictive cardiomyopathy with amyloidosis of the heart, and constrictive pericarditis. Contributing factors: old age, female gender, and obesity. Its constitution of patient for development heart failure with the preserved contractile function. Heart failure with a moderate reduced ejection fraction, like a heterogeneous group, which includes a group of patients with a predominant of diastolic dysfunction and concomitant small systolic dysfunction, which resemble patients with heart failure with preserved ejection fraction of the left ventricle. Patient with heart failure and improving decreased ejection fraction of left ventricle.
Excuse me, doctor. I just want to understand what does it mean, preserved ventricular fraction?
Preserved ventricular fraction?
Yes, if preserved is the right word for it.
Look, when preserved or normal ejection fraction, yes, because if we will assess contractility function during echocardiogram, and how we can assess with you this contractility of the ventricle, only to assess the level and volume of cardiac output. And preserved ejection fraction, it means that in fact this ejection fraction and cardiac output is normally, but the patient will have a problem as signs of heart failure.
Okay,
but,
so here,
but during examining, yes, you will administrate signs of heart failure, but during diagnostic value, you'll find that ejection fraction will be normally.
Okay, so he have a problem despite the ventricular, like the ventricular is totally okay, good, but he have a problem.
Problem with relaxation during diastole.
Okay.
Problem with the relaxation. So decreasing ejection fraction, it's a systolic problem. It's a systolic heart failure, in fact, problem with contraction. Diastolic heart failure, it's a problem with relaxation of the myocardium. Due to hypertrophy, can't relax myocardium. Due to pericarditis, pericardium inflamed and stopped the myocardium during diastole for relaxation. Continue. So it was all group of patients about etiology, about pathophysiology or physiology of heart failure. Heart contractility, stage and rate of contraction, ventricular performance, and myocardial oxygen demands are determined by level of preload for the heart, which depends from the level and volume of circulated bloodstream, level of afterload, which depends from the total peripheral constriction of the blood vessels, availability of substance like oxygen, fatty acids, or glucose, which contained in the general bloodstream, heart rate and rhythm, and available myocardial volume. Cardiac output is determined by stroke volume and heart rate per unit time. It's normal physiology. And it's also affected by the venous return and peripheral vascular resistance and neurohumoral factors. The level of preload is the state of the heart at the end of its relaxation and filling phase. It's a diastole filling phase and passive and active filling period of the ventricles immediately before contraction, before the systole. Preload reflects the degree of final diastolic tension of the myocardial fibers and the final diastolic volume, which is affected by diastolic pressure in the ventricle and the structure of the myocardial wall. And the final diastolic pressure in the chamber of the left ventricle, especially if it's above normal, is the main indicator of preload. So increasing the level of final diastolic pressure would depend from many reasons, and the most important it's a volume of general circulated blood. It's the main indicators of the level of preload for the heart. Afterload for the heart is the stage of resistance to the contraction of myocardial fraction at the beginning of the moment of the systole, and it's determined by the pressure in the chamber of left ventricle and the volume and wall thickness when the aortic valve is opened, the moment of start of cardiac output. In the clinical aspects, systemic systolic blood pressure determining during or immediately after the moment of opening of the aortic valve correlates with the peak systole tension of the ventricular wall. It's a peak, it's the high point of contraction, of tension, wall, and appropriate the magnitude of the afterload. Some moment about normal physiology regulation. You discussed the physiology, the law of Frank Starling, which describes the relationship between preload and heart function. Systolic heart function or contractility, and the main characteristic of systolic heart function, it's the level of contractility, it's the level of cardiac output or injection fraction by the ECG, represented by the stroke volume or cardiac output is proportional to preload within the normal physiological range. And contractility is difficult to measure clinically because it requires cardiac catheterization with pressure and volume analysis, but it's well reflected by the injection fraction, which we can diagnose and determine during echocardiogram, which is the ratio of the stroke and end diastolic volume after injection during contraction. It's ratio between stroke volume and end of final diastolic volume. It's the main science for assess contractility function of the myocardium. And if you look to this slide, look, all abnormalities in pericardium, all abnormalities in myocardium, including amyloids, decreasing contractility due to ischemia, development connective tissue in case of post-infection cardiosclerosis, all problem with the pericardium, increasing density, inflammation of pericardium, endocardium, and problem with the valves, leading to systolic abnormalities, leading to, what it is systolic abnormality? Decreasing systolic function, decreasing level of cardiac output or stroke volume, decreased contractility, and diastolic abnormalities, decreased feelings and compliance. So problem systolic abnormalities and diastolic abnormalities, two parts. Only two phases in the cardiac cycle, systolic and systole and diastole. So we can determine all problems in case of systolic and diastolic. All these problems leading to heart failure by two mechanisms. Heart failure, like a final stage, it's a decreased cardiac output. And in fact, all heart failure and systolic and diastolic in the final of this disease, it's a problem with cardiac output. It's a problem with blood supply. Decreased cardiac output leading to decreasing levels of blood supply or hypoperfusion. It's a sign, fatigue, development diffuse cyanosis, cool extremity due to decrease in the level of blood supply, renal involvement and developing chronic or acute kidney injury, and some confusions of consciousness. From another side, it's leading to backup of the blood, and it's leading to stagnation of the blood in the system of the pulmonary circulation, and it's a reason of developing pulmonary edema. And like a clinical signs, it's dyspnea and orthopnea. When in the last semester we discussed with you pathophysiology of the heart failure, we discussed with you that there are two types of the heart failure, clinically types. It's right side of heart failure and left side of heart failure. So right side and left side, decreased cardiac output. But in the first point, we activated, and the normal organism activated compensatory mechanism, which the main compensatory mechanism for regulation circulation of the blood. Left ventricular dilatation increased preload and thus increased the stroke volume, like compensatory. Activation of the sympathetic nervous system, which activated all chronotropic positive effects for the heart, increased heartbeat, systemic vasoconstriction, and increasing and intensifying the level of the blood pressure, and the nodus vasoconstriction, partly. The last mechanism of compensation is activation of the renin-angiotensin-aldosterone system with the sodium and water retention that increase preload and stroke volume from another side, and systemic vasoconstriction due to disbalance between the action of angiotensin II. All these compensatory mechanisms leading to next points of effects: exacerbation of symptoms and increased cardiac remodeling, increased and rounded cardiac remodeling, further decrease in contractility, mitral regurgitation, and in this case it will be relative mitral regurgitation, which will be caused not about valve damaging, which will be caused about dilatation of left ventricle and dilatation of the ring of the mitral valve, and left atrial enlargement and atrial fibrillation. Next group, increased myocardial demands and worsening of pre-exciting ischemia, caused decreasing by the level of blood supply, total blood supply, and blood supply of the coronary arteries. And also volume retention leading to pulmonary edema, worsening the symptoms of pulmonary edema and systemic edema due to sodium and water retention in the kidney. And all these problems aggravated exacerbation of the heart failure. So returning to the pathophysiology of left heart failure or pathogenesis. Which pathophysiology mechanism? Which one? Dilated cardiomyopathy can be a reason, mitral or aortic regurgitation, myocardial infection, severe hypertension and thus aortic stenosis, cardiac tamponade, myocardial ischemia, hypertrophic cardiomyopathy, myocardial fibrosis, restrictive cardiomyopathy. So, dilated cardiomyopathy leading to myocytes loss and intestinal fibrosis, leading to decrease in left ventricular contractility, decreasing of left ventricular contractility leading to development systolic dysfunction. Contractility, problem with contractility, leading to decrease in cardiac output stroke volume. It's a problem with the systole. So systolic dysfunction. Left ventricular cannot squeeze and empty well, which leading to decrease in ejection fraction. Left ventricle cannot work in and output in blood normally. Systolic dysfunction and decrease in ejection fraction leading to development signs of left heart failure. Left ventricular stroke volume decreased, reducing cardiac output, not enough blood is pumped into systemic vessels to meet body, to blood supply, to making metabolic demands. Blood backs up into the lungs, causing by the pulmonary edema, to the pulmonary congestion of the blood. Symptoms and signs of decreasing cardiac output, forward failure, and congestion, backward failure results. Mitral aortic regurgitation, myocardial infarction through the mechanism of chronic volume overload, leading to left ventricular dilatation and hypertrophy, leading to left ventricular contractility, and doing by the similar scenarios. Myocardial infarction, necrosis, non-functional cardiomyocytes, post-infection cardiosclerosis, connective tissue, fibrosis, leading to decrease in contractility, the same scenarios. Severe hypertension and severe arterial hypertension, and advanced aortic stenosis of the aortic valve, leading to increasing resistance to left ventricular injection due to total constriction, increasing in the total peripheral blood vessels, increasing resistance to left ventricular injection. It means increasing afterload. It's leading to chronic left ventricular pressure underload, pressure to left ventricle, pressure due to constriction. It's leading to left ventricular dilatation due to increasing afterload, hypertrophy, and fibrosis. Left ventricular dilatation leading to decreasing systolic dysfunction. Next, the same scenarios. Cardiac tamponade, myocardial ischemia, hypertrophic cardiomyopathy, leading to decrease in left ventricular relaxation. Left ventricle can't relax normally during diastole, during the passing inactive feelings of ventricular, so it's not enough volume inside the left ventricular, leading to decreased blood which can entrance in diastole in the chamber of the left ventricular, leading to decreased left ventricular and diastolic volume. And it will be already a moment of increasing preload for the heart, leading to diastolic dysfunction, can't relax. Left ventricular can't relax while even through ejection fraction is preserved, and also again the same scenarios, all signs of left side heart failure. Myocardial fibrosis, restrictive cardiomyopathy, increase in left ventricular wall stiffness, density of the structure of the myocardium of the left ventricle as you want, leading to decreased left ventricle and diastolic volume, leading to development diastolic dysfunction, leading to development signs of left side heart failure. You should know that left ventricular failure is the most severe end stage manifestation of many forms of heart disease, and in fact it's a final stage of all cardiovascular pathology due to all mechanisms which we discussed. That's why we discussed chronic heart failure like the last topic in the point of cardiovascular pathology. Next picture about pathogenesis of right side heart failure. Right side heart failure. Cardiac disease, first group. Right ventricular infection, chronic coronary disease. Right ventricular cardiomyopathy, which affected the chamber of the right ventricular more. Pulmonic valve disease, some problem with the valve of the pulmonary artery. Left heart failure, which leading to increase in pulmonary blood pressure, which leading to stagnation of pulmonary hypertension. Tricuspid regurgitation due to bacterial endocarditis, acute rheumatic fever. Death of right ventricular myocardial tissue, leading to decrease in contractility of the right ventricular myocardium. Tricuspid regurgitation, for example, leading to chronically low right ventricular ejection fraction. Tricuspid regurgitation, volume of one part of the volume from the right ventricle, not only to the system of the pulmonary circulation, but regurgitation to the right atrium. So decrease in contractility like a result, and chronically low ejection fraction from the side of the right ventricular, leading to failure of the right ventricular and decreased right ventricular stroke volume in the system of pulmonary circulation. Disease of the lung parenchyma, another group of disease, cause not only cardiac disease, can be a cause of developing right side heart failure. Chronic obstructive pulmonary disease and COPD in case of formation chronic pulmonary heart, intestinal lung disease, respiratory distress syndrome, chronic lung infection, and development a lot of bronchiectasis, leading to disease of the lung parenchyma problem, the first problem in the lung parenchyma. Then leading to hypoxic alveoli caused by pulmonary vascularity, to reflexivity vasoconstriction and blockage some part of parenchyma through the blood supply and through the circulation. Disease that affect with pulmonary vascularity, acute pulmonary embolism and thromboembolism of pulmonary artery, primary pulmonary hypertension like a separately disease, and some other disease of with the autoimmune mechanism like a scleroderma, like a erythematosus lupus, like a rheumatoidus arthritis, and HIV with damaging of the valve structure and myocardium. All these problems from the disease of the lung parenchyma and another disease which is associated with the lung parenchyma, leading to right ventricular chronically exposed to high level of the afterload, leading to increase in right ventricular wall tension and stretches sides myotelements to longer than the optimal contraction length. Disbalance in the stretching and optimal balance between the stretching and relaxation of the myocardium myofibrils of the right ventricle, leading to having to inject blood out from the right ventricle, including Frank starting closing some parts. It's leading to failure of the right ventricle, decreased right ventricular stroke volume. Key problem, the main problem, it's again decreased injection fraction of cardiac output from the chamber of the right ventricle to the system of pulmonary circulation. So, decreased right ventricular stroke volume leading to two ways. Blood back up into the systemic of the nosus vascularity, it's leading to blood accumulating dense before right atrium, including the internal jugular vein, and it's leading to high abdominal jugular reflex is positive signs of right ventricular cannot pump more than nosus blood into the lung. And these clinical signs like abdominal jugular reflex. Next, increasing the nosus hydrostatic pressure, increase bulk flow of fluid out of capillaries into the systemic tissue, and it's a point of development peripheral pitching edema. Starts at the feet usually, moves up as the nosus congestion worsening, and eventually presents as ascites. Started from the feet, because it's normally it's a physics, yes, that's a hydrostatic hydraulics when the way of a liquid from the up to the down. So firstly started on the lower extremities and going up due to aggravation. And also it's leading to congested liver and spleen and congestion and stagnation. And it's a cause of developing hepatosplenomegaly. Firstly, it's hepatomegaly. In the last stage, it's hepatosplenomegaly due to stagnation of the blood. And it's right upper quadrant discomfort or some stretching or some pain in the projection of the liver. Another way, next way of the failure of the right ventricle still needs to pump against high afterload and high resistance pulmonary vascularity, leading to shut pulmonic valves with greater than normal force. And like a sign, we can determine loud pulmonary component of second tone, and may be palpate, and you can assess this palpation above the pulmonary artery due to palpation of the heart. And it's leading to compensatory remodeling of right ventricle to develop in right ventricular hypertrophy, and after that dilatation or enlargement of the chamber, right ventricular head, during palpation, or increasing the body of the relative dullness of the heart, right body of the relative dullness of the heart due to percussion, and all clinical signs during palpation of right ventricular dilatation. Look, the most common cause of right side heart failure is left side heart failure. In all regions, the most common and the most important, it's a left side heart failure. And after that, in the case of decompensation, the patient take it two ways, two sides of heart failure. Isolated right ventricular failure, not due to a left heart failure in the base, is called like a core pulmonary, and we discussed it with you in the topic about chronic obstructive pulmonary disease and bronchial asthma. Other clinical findings of right side heart failure depend on the specific underlying cause, for example, dyspnea, like a sign of COPD. Some words about epidemiology of heart failure. According by the last research of World Health Organization, the prevalence of chronic heart failure in the general population was 7%, which including clinically expressed heart failure in the average between 4.5%, increasing from 0.3% in the age group from 20 to 29 years, to 70% in the people other than 90 years of age or in more elderly patients. Is usually, yes, it's a map with the gradation of cardiovascular disease, global cardiovascular disease, like we discussed with you, with prevalence of the chronic coronary disease in the Europe with the high development countries, and like a final stage, it's development of heart failure, stagnation of heart failure. So returning to classification, our first slide was about the last classification of heart failure by the ejection fraction. But there are another classifications of heart failure, clinical classification. First of all, in general, heart failure, we can differentiate it with you for acute heart failure and chronic heart failure. And our key and our view at this lecture will point it to the chronic heart failure. But what is acute heart failure? It's occurrence of acute or cardiogenic genesis shortness of breath, which associated with very rapidly development of congestion in the lungs, till the pulmonary edema, or cardiogenic choke, which as a rule as a result of acute myocardial damage, especially acute myocardial infarction. So we discussed with you that myocardial infarction is the main cause of developing chronic heart failure, like a group of coronary heart disease. But look, in the moment of problem, in the moment of acute stages of acute coronary syndrome with ST elevation, for example, we will classify it with problem with pulmonary edema like acute heart failure. It's impossible to be in red and blue in the same time. You can classify heart failure or acute or chronic heart failure. And in case of decompensation of chronic heart failure till the acute problem, it will be again acute heart failure, and after that you're recovering the patient to the chronic heart failure by different stages. Chronic heart failure determines the stage of heart failure, which used the classification by the New York Heart Association and stages by American Heart Association, clinical classification of chronic heart failure. Firstly, about New York Heart Association of severity of heart failure. So NYHA class 1, 2, 3, and 4th, by the degree of physical activity which is associated with the shortness of breath, or in other symptoms. But the main symptoms of clinical symptoms of heart failure, it's a shortness of breath due to cardiogenic problem. So class 1, no any symptoms with normal physical activity and normal absolute functional status, but the patient already had a substrate for development heart failure. For example, previous myocardial infarction. We knew about substrate but no any clinical signs of heart failure during normal physical activity. Second class of heart failure, some mild symptoms with normal physical activity, comfortable at rest, absolutely comfortable at rest, and slight limitation of functional status. Maybe patient or without control or will limitate the level of physical activity. A third class by the NIHA, moderate symptoms, which less than normal physical activity, comfortable only at rest for patient, and marked limitation of functional status of patient. And fourth class by the NIHA, it's severe symptoms of heart failure with features of heart failure with minimal physical activity and during the rest and even at rest, even the calm condition, and severe limitation of functional status. Symptoms of heart failure, fatigue, palpitation, chest pain, dyspnea, and syncope. But like a clinicist, we can change the place of the symptoms, and clinically the most important for us, it will be dyspnea, maybe chest pain due to decreasing the blood supply and decreasing blood supply due to coronary artery through the coronary artery, which aggravated the symptoms of coronary heart disease. And after that, fatigue and palpitation from the side of the patient. So, stage classes by the New York Heart Association and stages by the American Heart Association, and association stages with the classes, functional classes by the NIHA. About stages, stage A, high risk for the development chronic heart failure, already had a substrate, but no structural disorders of the heart. Maybe arterial hypertension substrate, yes, it's a substrate, but no structural disorder of the heart yet. Stage B, structural disorder of the heart, never developed symptoms of heart failure. We knew about myocardial infarction in the past. We knew about some decrease in contractility of the left ventricular, but never developed symptoms of chronic heart failure from the side of the patient. Stage C, past or current symptoms of chronic heart failure, symptoms which are associated with underlying heart disease. And stage D, end-stage disease of heart failure, requires specialized treatment strategies. Stage B associated with first functional classes with no limitation of physical activity, but we knew about substrate and we can touch the substrate. Stage C, yes, associated with the third functional classes by the NIHA, marked limitation of physical activity, comfortable at the rest. And stage D, the last stage, associated with the fourth functional classes. Third class by the NIHA, also we can separate it by two subcategories, third A and third B. Third A, no dyspnea during the rest, and third B, rest and dyspnea at the rest. In fact, third A show us that stagnation of the blood represented by the one cycle of circulation. Third B show us that stagnation of the blood associated with both cycles of circulation, and in fact it's already full heart failure, right side and left side heart failure. Also, that's important that you can't change and you can't formulate it in formulation of diagnosis. You can't change the stage of the heart failure, but you can reduce of functional classes of the patient with heart failure due to treatment during your treatment, and you can improve the functional classes due to reducing clinical signs like dyspnea, fatigue, and impossibility of physical activity. No change stages, but reducing, changing the functional stages classes by the New York Heart Association in the formulation of diagnosis. And in fact, it will be it shows your results of the treatment. Returning to classification, reduced injection fraction, borderline injection fraction, and improved injection fraction. So, diagnostic moments of heart failure. For the diagnosis of the heart failure, the following criteria are required. We need to find with you some specific symptoms of clinical signs: general fatigue, palpitation, dyspnea, decreasing blood supply, edema, peripheral till the total edema. Next, objective examination dates which indicate cardiac dysfunction during the rest due to large increased level of physical activity, the exclusion of other disease, the exclusion of other nature of this problem, condition that had a similar clinical picture. For example, we need to differentiate it with dyspnea in case of pulmonary embolism, dyspnea in case of COPD, and dyspnea in case of chronic heart failure. In doubtful cases, the positive effect of ongoing diuretic therapy, determination of the concentration of natriuretic peptides. Compliance patient with chronic heart failure. Symptoms of heart failure manifested themselves in various forms, and it depends on which part of the heart muscle most affected. Darkness in the eyes during decreasing blood supply, fainting, some dizziness, swelling of the cervical veins, different types of arrhythmias. Pallor of the skin, pain in the legs due to stagnation, due to edema of the legs, swelling of the lower extremities, and increase in the size of the liver and spleen because of hepatosplenomegaly, and the presence of the free fluid, additional fluid, into the abdominal cavity and into the thoracic cavity. During collection of anamnesis, it's recommended to pay special attention to the presence of the patient history about previous heart pathology, which lead into functional or structural changes. A long history of arterial hypertension, a previous myocardial infection, or inflammatory myocardial disease, like a pericarditis, like a bacterial endocarditis, like acute rheumatic fever, significantly increase the likelihood and ability of the heart failure in patients with above compliance. From another side, the absence of indications when collecting of anamnesis about exciting heart disease minimize the chance of heart failure in a patient. Minimize, but not exclude at all. For what we have to put our attention in case of physical examining. It's recommended that the physical examining be performed to identify symptoms and clinical signs due to sodium and water retention. And in fact, we should put our attention to assess the level of edema and shortness of breath. We can classify with you symptoms of heart failure by typical and less typical. It's not a non-typical. It's a less typical for heart failure, but also it can be a causes and symptoms of the heart failure. Typical, third place, dyspnea or shortness of breath. Orthopnea and position of patient with orthopnea. Next, paroxysmal nocturnal dyspnea. Just a moment, I need to answer. Наталья Валентиновна, у меня лекция, да. Срочно, не срочно? Чего? Понятно. Угу. Понятно. Но он пересдал хирургию, 2 штуки. Нет, и не то, да? Угу. 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 Господи, да какая уже разница? Уже и 3 поставьте ему, он даже 3 будет рад. Я поняла, и он выставил другие оценки. Да что-то вряд ли, мне кажется, это просто его слетел, если честно. Ну, Бореева телефон у меня есть, то есть он со мной всегда на связи. Хорошо, да, я так и сделаю. Я ему сейчас после лекции позвоню, его к вам отправлю. Ну, мою он возьмет, Да, да. Да, все, Наталья Валентиновна, все. I'm sorry, so continue. Typical dyspnea, a position of orthopnea, which we can explain by the increasing of preload to the heart in patient with heart failure. Paroxysmal nocturnal dyspnea, reduced exercise tolerance, it's impossible to do interstitial activity normally. Weakness, fatigue, increased recovery time after exercising, and the patient enlarge the time for the resting after exercising and any interstitial activity, and an increase in ankle volume, edema. Less typical signs of heart failure. Night cough, it can be caused by the bronchial asthma, for example, and we need to differentiate this cough. Wet wheezing, caused wet wheezing associated not only with pulmonary edema, it's associated with the pneumonia and another inflammation process of parenchyma. Weight loss, decreased appetite, it can be caused by the problem with the esophagus or stomach. Weight gain, more than 2 kilograms per week. It can be caused not only by collecting the additional fluid in case of total edema. Bloated sensation and disorientation of the patient, especially in the elderly age, because we need to exclude some neurological problem. Also, depression, heartbeat, and syncopal condition. So less typical signs can be caused by another reasons, by another nature, but it also can be signs of chronic heart failure. Symptoms, clinical signs, more specific for heart failure. Increased central venous pressure in the jugular veins, hepatojugular reflux during interstitial examining, third tone, and formation the special rhythm like a gallop rhythm, which significantly for heart failure. And if we return into mechanism of formation third tone, the third tone formed when the bloodstream through the mitral valve, through the tricuspid valve in the period of patient thinnings of the ventricles, contact with the hypertrophied and dilated cardiomyocytes of chambers of ventricles. Shift of the apical impulse to the left side due to palpation, and development heart murmur, and exactly a heart murmur like a relative mitral insufficiency. Less specific clinical signs. Peripheral edema can be caused by another reason, but associated with heart failure. Auscultation crepitus, tachycardia, irregular heartbeat can be caused by, firstly, by the arrhythmias. Tachypnea and respiratory rate more than 6 per minute. Hepatomegaly can be caused by the hepatitis. Developing ascites can be caused by protein insufficiency and cachexia. Patients with a mild heart failure show no any pathological symptoms after several minutes of rest, but they may have rhabdosis, shortness of breath during or immediately after moderate interstitial activity or enlarged level of interstitial activity. Patients with left ventricular failure may have shortness of breath or a feeling of a lack of air while lying down without raising their heads for more than a few minutes, and it's a specific position of heart apnea. In more severe patients, a decrease in pulse pressure due to low cardiac output and an increase in diastolic blood pressure due to peripheral vasoconstriction can be detected, decreasing in the level of the pulse pressure. Pulse pressure, it's a difference between systolic and diastolic pressure. Also possible to detect cyanosis of the lips and nail beads and the signs of acute cyanosis, sinus tachycardia, and it's difficult for patient to lie, and they spend more often of their time like during the sitting. Venous pressure in a large cycle of blood circulation is often increased and swollen cervical bands indicate this. And in the elderly stage of heart failure, swelling of the cervical bands may be absent at rest, but may appear with exercise or immediately after in and with a pressure on the stomach. Edema of lower extremities occurs equally on the both legs. It's absolutely simultaneous process, usually worsening in the evening, and they are localized mainly in the ankles and legs, and after going up with the aggravated condition. In bedridden patient, all edema moves to the sacral region, and we discussed it with you in the previous semester, why and move to the sacral. In severe heart failure, swelling of the hips, scrotum, lumbar region, lower part of the anterior abdominal wall also possible to detect. In the late stages of the heart failure, an increase in the abdomen due to ascites is significant. Also, it can be a reason of developing jaundice due to hepatomegaly, pallor of the skin, or cyanosis of the skin. In the large stages, it will be mixed type of cyanosis in combination with acral and diffuse cyanosis. Patients with a newly developed heart failure usually have normal body weight, but chronic heart failure often results in malnutrition and sometimes even to cachexia. And in this case, very important to differentiate it. Cachexia with the enlargement wave due to collect additional fluid, or it's really obesity. Next moment during our physical examination is palpation. Pulse in chronic heart failure in most patients is rapid, small feeling and tension during palpation in the main arteries. Very often the pulse is arrhythmic due to extrasystole or atrial fibrillation, close stretching of the atrials can be a reason of atrial fibrillation. A characteristic sign of severe heart failure is an alternating pulse. Some patient develops a bradycardic form of chronic heart failure, which is characterized by a rare pulse. A cardiac impulse in chronic heart failure is shift to the left, and apical impulse, which formed by the apex of the left ventricle, shift to the left, and sometimes simultaneously some downward due to dilatation left ventricular. And the cardiac impulse becomes diffuse. Its area exceeds 2 by 2 centimeters in the total square. With significant hypertrophy and dilatation of the heart, pulsation in the anterior region of the heart can be noticeable, with predominant or isolated hypertrophy of the right ventricle, for example, with the chronic pulmonary heart. And we can assess this pathological pulsation in the region of the cardiac impulse above the projection of the heart right ventricle, and pathological pulsation in the epigastrical region due to dilatation right ventricular, which more significant in the high point of inspiration due to decrease in the level of diaphragm. Percussion of the heart region started from the lungs. Percussion of the lungs, we can identify with you some shortening, some dulling of percussion sound in the lower part of the lungs, which may be due to congestion, due to pulmonary edema, and some compaction of the lung tissue, but more preferred congestion and pulmonary edema. So in the upper part, you will determine clear pulmonary sound. During comparing percussion in the lower part of the lungs, you will determine some dullness and shortening of the percussion sound. In case of hydrothorax formation, due to collecting additional fluid in the chest, during percussion of the lungs over the area of the fluid accumulation, and usually from the angle of the scapulus down and at the same level along the axillary lines, and the dual sound is determined also. And in this zone, vesicular respiration and additional respiratory sounds are absent absolutely, because additional fluid represented not in the alveolar cavity, it's represented in the thorax cavity. In case of percussion of the heart, we can determine with you a shift in the left border of the relative dullness of the heart due to dilatation of the left ventricle, and with pronounced chronic heart failure due to valvular death, due to developing relative mitral insufficiency, dilated cardiomyopathy, post-infection cardiosclerosis, in case of aneurysm of the left ventricle and other disease, leading to severe dilatation of the heart, including dilatation of the left and right ventricle, and significantly shifting the both and left and right borders of the relative dullness of the heart. So wider the borders of the relative dullness of the heart to the both sides. During percussion of the organs of the abdominal cavity, we continue with the plan our physical examining. A characteristic sign of ascites in severe heart failure is an increase in the size of abdomen, and we can assess it visually. Also, above the abdominal cavity, pronounced shorting dulling of percussion sound in the flat areas of the abdomen, and a positive symptom of fluctuation when you will assess in the presence of additional fluid in abdominal cavity during palpation. Auscultation. Auscultation of the lungs. And in patients with chronic left ventricular failure, crepitus and moist and wet small bubbling rails are often heard in the lower section of the background on hard or weakened vesicular breathing, cause it's a pulmonary edema, and wet wheezing will be caused by the additional fluids which are represented in the alveolar space, and also on the background of the attenuation of vesicular breathing. Crepitus is heard only during inspiration and resembled by the noise of hair friction above the ear, and it's caused by chronic venous congestion of the blood in the lungs, intestinal edema, and impregnation of the walls and the alveoli with the liquid. During auscultation of the heart, in almost all patients with chronic heart failure, you will determine some attenuation or weakening of the first and second cardiac tones, cause decreasing the valve components and decreasing the muscular components due to decreasing constriction, and perceived as a diff, especially first tone. And however, with the development of pulmonary hypertension, we can determine with you some ascent in the second tone above the pulmonary artery in the second intercostal space from the left side of the sternum. In the presence of right side heart failure, a decrease in contractility and a slowing of the expulsion of blood from its cavity. And splitting of the second tone is hard due to a delay in the appearance of the pulmonary component. A characteristic auscultatory manifestation of severe heart failure is the rhythm of gallop. It's a component with including a third pathological tone due to heart failure. The gallop rhythm is a pathogenical free-member rhythm which consisting of a weakened first tone due to relative insufficiency mitral and tricuspid valve, second tone, and a pathological additional tone, third or fourth, very difficult to differentiate it, appearing against the background of tachycardia due to compensation and activation sympathetic adrenal system and renin-angiotensin aldosterone system, indicating severe heart failure and resembling a galloping horse. With severe dilatation of the left ventricle, relative mitral insufficiency develops and systolic murmur of mitral regurgitation is heard in the region of the apex of the heart, which provides into the axillary region. With significant dilatation of the right ventricle and right side heart failure, relative tricuspid valve insufficiency is formed, and which caused the appearance of systolic murmur of the tricuspid regurgitation in the point of auscultation of tricuspid valve and the basoxiphoid process. So it was about physical examining. Next, we'll continue with laboratory diagnostic methods for examining heart failure. All patients with heart failure are recommended to determine the level of natriuretic hormones to verify the diagnosis of heart failure. And in fact, it's the first and the most important, the gold standard, if you want, in the diagnostic of the heart failure. to verify the diagnosis of, and look, I put it by the red color, but to determine the natriuretic and atrial-uretic peptide, not exclude the taken general analysis. So general blood tests to exclude the elimination of enemy, which can be a provoke of worsening condition of the patient, assessment of platelet and white blood cells count in case to exclude bacterial problems. Biochemical blood test, determination of electrolyte levels of potassium and sodium, and in fact it will be signs of activation renin-angiotensin aldosterone system, level of creatinine, like a sign of damaging and marker of damaging of the glomerular filtration rate, and glomerular filtration rate calculated by the indicators by the chronic kidney disease epidemiology formula. We need to indicate in glucosage, glycated hemoglobin, lipid profile to identify the nature of the key problem, and liver enzymes and general clinical urine analysis. Not excluded, yes? But the main determination to confirm the diagnosis of heart failure, we need to know the level of natriuretic peptides. At present, that closer relationship between the severity of cardiac dysfunction, primary the cardiac dysfunction of the left ventricle, and the content of natriuretic peptides in plasma is fully proven. And which allows us to recommend determining the concentration of these type of peptides is a laboratory test of a chronic heart failure. Levels of natriuretic peptides allows us conduct effective of screening among previously untreated patients suspicion of head and left ventricular dysfunction, conduct differential diagnosis of complex forms of chronic heart failure, diastolic or asymptomatic, and accurately assess the severity of the left ventricular dysfunction, which are related with the level of natriuretic peptides. Determine the indication for the treatment of chronic heart failure and evaluate the effects after our treatment, and assess the long-term prognosis of chronic heart failure. Which types of natriuretic peptides we can determine? N-terminal atrial natriuretic peptides, natriuretic peptides, which we discussed with you in case of arterial hypertension, which produced due to stretch in the myocardium of the left atrium. Brain natriuretic peptides, more prefer, and some preform of brain natriuretic peptides level. It should be remembered that the level of natriuretic peptides can also be increased with the number of some other cardiovascular pathologies. Left ventricular hypertrophy can be. Damage of the heart valves due to stretching can be. Myocardial ischemia, arterial hypertension, and pulmonary embolies. It has been shows that the most justifiable from a clinical point of view seems to be the use of this test, not so much for confirmation as for excluding the diagnosis of heart failure, since the test has an extremely high negative predictive value. And it's known that the normal level of the natriuretic peptide depends on the age, gender of the subject, measurement methods, and in the population correct from the 0.5 till 30 picograms per milliliter. Laboratory diagnostics, natriuretic, atrial natriuretic and brain natriuretic peptide, and some in other concurrence laboratory tests. Instrumental diagnosis. Usually we start from the simple to difficult. To verify the diagnosis of heart failure, all patients recommended to perform an ECG with assessment of the heart rhythm, heart rate, morphology and duration, complex of QRS, presence of atrioventricular and ventricular conduction disturbance, left bundle branch block, right bundle branch block, myocardial damage, myocardial hypertrophy, signs of all these problems. The diagnosis of heart failure is absolutely unlikely in the presence of completely normal ECG. If your patient had an absolutely normal ECG with without problem with conduction, without problem with complex QRS, without problem with the heart rate and the rhythm, it's not a heart failure. To verify the diagnosis of heart failure, all patients recommended to perform echocardiography or ultrasound of the heart. To assess the systolic function of the left ventricular, it's recommended that all patients need to calculate the level of ejection fraction of the left ventricular. And all patients, and after this assess, we can classify systolic or diastolic problems. All patients with chronic heart failure are recommended to evaluate the diastolic function of the left ventricular, ability for relaxation, assess systolic function to measure ejection fraction, and assess diastolic function of the left ventricular, ability of relaxation during diastole. Next moment, chest X-ray is recommended for evaluating the cardiothoracic index. For determining cardiomegaly, cardiothoracic indexes should be more than 30%. For diagnosis cardiothoracic index, you need to measure the duration by the scale. You can do it by the visual way, the duration of the chest from the one side, from the one lateral to another one, and diameter of the chest and diameter of the heart, and calculated this index. Excluding pulmonary hemodynamics, we can exclude venosus, pulmonary arterial hypertension signs, sinus effusion and collect additional fluid, pulmonary edema, and also to detect some disease of the lungs and to make alternative diagnosis for patients with heart failure. The result of X-ray diagnostic of the chest organs required comparison with the clinical picture and ECG. We need to assess, yes, we need to collect information. About additional methods. In some cases, due to the clinical situation, additional research methods complementing each other and helping the alternative diagnosis of various cardiovascular disease. The choice of each of them is determined by diagnostic capabilities and the risk of the side effect. Which additional methods? Surely, if a patient with coronary heart disease had acute problem or had a subtotal sclerosis of coronary artery, coronarography. Radionuclide diagnostics of the heart, MRI with contrasting. Cardiac catheterization, test with the load. Transesophageal echocardiography, and the indication for transesophageal echocardiography, it's not good, not enough visualization through the transthoracic echocardiography. Stress echocardiography with dobutamine with stimulation of sympathetic adrenal system. Multispiral computed tomography in case of determining some problem with coronary arteries. Magnetic resonance imaging with contrast or without contrast. Spiral computer tomography with contrast or with another contrast, like additional methods. It's preserved by the last clinical guidelines about chronic heart failure, which was established in 2080, to my mind. The last forms was established in 18th year. And like a last slide in our lecture, we should look with you these two pictures, which show us the condition of the heart and in fact its condition of our patient with different class of limitation of physical activity by the New York Heart Association. First class, no limitation physical activity, absolutely ordinary physical activity does not caused by the symptoms of heart failure. Second class, functional class, slight limitation, not so good feeling, comfortable during the rest, ordinary physical activity cause the symptoms and decrease the level of physical activity and decrease the quality of life of our patient. Third class, marked limitation of physical activity, more comfortable and more staying in the rest, but less than ordinary activity causes symptoms. And fourth class, it's severe limitation, discomfort with or without physical activity during, absolutely during the calm breathing, during the calm condition. So that's all.